Start recording. So here we go.
Mhm.
Okay. Okay. So welcome everybody. And I'm going to introduce Morgan. Morgan is in Chico with me.
Oh,
Yeah, osteopath here. And she is going to help us understand the pelvic floor more deeply and has a really great schedule of things for us to cover today. Did everybody make sure to bring a hand towel to this party? I could not find my tennis ball.
I had a whole bunch. I
I know. Okay, very good. Okay, so Morgan, take it away.
Hello. I am like super excited. I love talking about pelvic floor. Um, so are there, before you even jump in, since there's only three of us in this actual call right now, is there anything that you guys specifically want to have discussed? I have a program, but I can shift around and move a little bit. So are there any known, like, oh, this is confusing, or oh, I'd like to know about this before we jump in?
think I'll ask questions as you talk for sure.
Perfect.
Yeah.
Yeah,
Good.
probably. Like, I don't know what I don't know, so
Totally fine. Well,
I'm willing
sometimes
to
we
soak
just
it
go
up.
into these, yeah, when we've just like done something, right? It just kind of percolates in there and there's something that isn't quite connecting. So, if you have questions at any time, don't hesitate to ask. I'm not super well versed on using Zoom, so if I miss your question, maybe Kara can just make sure I hear it or something. I'm not quite sure how that will work, but please stop me at any time. Yeah, I can see it, but I think when I put my thing on, I don't know how much I can see. So, yeah, just a little bit about myself quickly. I am a manual osteopath, so I trained in Canada. I've been working on table work for about 10 years. I've taught Pilates and biomechanics and movement and kinesiology for 26 years. So I kind of have a unique understanding of how things work. It's not just musculoskeletal, it's the whole system. So we'll be looking kind of at pelvic floor from a larger systemic way of how we actually live in our pelvic floors, not just like a Kegel exercise, for example. Um, so we're gonna tuck in. I'm gonna just smoothly transition into sharing my screen. It's gonna go so easy. Um, Give me a minute. There we go. Okay. So are you seeing my little slide deck there?
Yes. Yep.
Perfect. Okay. And it's like full size on your screen?
Yes.
Yeah.
Okay. There we go. Perfect. Oh, and I can see all of you too. Huzzah. All right. So, please stop me if I'm not making sense or if I'm talking too fast as well. So, pelvic floor, as you guys know, um, it's just the sling of muscles that exist at the bottom of our pelvis, right? So the things involved are the muscles of the pelvic floor, the sacrum, and the innominate bones, right? And we've been taught it's a sling. And I've seen research that actually shows that it's not a sling, but that it's a dome, just like our respiratory diaphragm, which kind of makes sense to me. And when we do cadaver dissections, we do them on um, dead people. What happens when we die? Right? Everything kind of sags, we lose our tone. So I think there's less of this sling structure and more of a level structure or even a slight dome to pelvic floor in health. But we rarely look at people in health. We look at people who are in disease. So we see dysfunction more than we see normality. So I'm a little curious. It doesn't necessarily have to be a dome, but it is made up of these muscles here. So this is the predominant muscle of your pelvic floor. It's called your levator ani. Have you guys done this part? You're aware of all these? Yeah, yeah. Okay. So puborectalis, pubococcygeus and iliococcygeus. Yeah. So that's our levator. We also have other muscles that make up our pelvic floor here, which is the coccygeus. And then another really important one is your obturator internus here. And in this view, that's your piriformis. So
Mm.
those are the basic muscles of your pelvic floor. The function of our pelvic
Mm.
floor is predominantly support. So it supports our abdominal organs. It supports and stabilizes our pelvis and our SI joints. Um, it has sexual function and it has evacuation function, right? In urine, fecal matter, and babies. So this hole here is your urogenital diaphragm or hiatus, sorry, urogenital hiatus, and that's where your vaginal canal is in women, and that's where your urethral sphincter is. And this here is your anal hiatus. So those are where things move through our pelvic floor, and this is typically where we tend to be the weakest, is this inner ring, this inner puborectalis muscle. So now that's our inner layer. This is the more supportive function of our pelvic floor. Okay. I don't know if that picture was small, but there's a bigger one. And then we have the external layer of our pelvic floor, or the urogenital layer of our pelvic floor. So this is where our sphincters live. So for both men and women, we have the external anal sphincter, and we have the urethral sphincter in women. So this is what it looks like in a woman. I think it's so beautiful. You have this lovely little figure eight. There is some supportive function here, but this is more functional. Okay, and this is women. This here, the bulbospongis muscle, is what becomes the muscle of the penis in men. So again, here's just another picture. Perineal muscles. This is your levator group. Here in the center, when you're looking at the tissues, the skin, this is the central tendon of your perineum. So this is the very center of your pelvic floor, which is going to align with the very center of your diaphragm. Okay, we're going to talk about that too. So this is, of course, female. And I have to point this out because it never gets pointed out. This is the glands of the clitoris in a woman. Okay, this is the tip of the clitoris. I don't know if you guys have seen the research, but now they've seen, and I have a picture of it if you want to go there. But the clitoris is an organ that extends 4 centimeters on either side, and there are actual bulbs and a long piece that surrounds the vaginal canal. So it's really important that we take in consideration all the parts. We've cut out the clitoris for so long. It just makes me really sad. So if you guys want to see that, I have a picture of that if you want to go that direction. But it's important because it's a vital piece of anatomy in this area for women. For men, here, I'll go back one, the bulbospongis muscle here, and the external urethral sphincter here for women. And for men, this is the bulbospongis muscle that surrounds the corpus cavernosum of the penis and the ureter inside. Same parts, just built a little differently. Okay. Other things to look at here. This guy, can you guys see my pointer?
Mhm.
Okay.
Yeah.
So this is your sacrotuberous ligament. You guys have worked with this and discussed this. Okay, good. And then this here is the sacrospinous ligament. This is going to become important when we talk about a couple of muscles. Again, for orientation, piriformis, and obturator internus. It's nice to see it from like a million different angles. Kind of helps wrap my brain around the fact that we're three-dimensional. Looking at two-dimensional pictures. So here we go. Here's the ligamentous structure of your sacrum. So again, we have sacrotuberous ligament, and then we have the sacrospinous ligament. This is the external anal sphincter, glute max, and then obturator internus again. And if any of you have the opportunity to do dissection, oh my gosh, please go dissection, 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 and do them as fresh as you can. Those tissues change the instant that they touch air. So if you can go to not a fixed dissection, you're going to see a wholly different experience. And I say that because this is so pretty. Look at how clean and neat that is, that this ligament goes from here to here, and this goes from here to here. It is not that pretty. It is not that neat. This is all kind of contiguous, right, with your lumbosacral fascia. Everything is just all in the mix. So think about that our hamstring tendon is contiguous with the sacrotuberous ligament, which is contiguous with this structure of our sacral joints, right? Which is contiguous with that thoracolumbar fascia, which is contiguous, da 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 da. So it's all connected. So just bear that in mind as we go in a little bit further to the pelvic floor innervation. And you guys might not need to know the exact innervation, but it's really fascinating because there's so much going on with our pelvic floor. The pelvic floor muscles the levator ani actually have smooth muscles within them. So they're not just strictly skeletal muscle. And a lot of this can be attributed to the fact that we give birth, right? So there's an autonomic process that's happening in birth. And when we give birth, we tend to think, oh, the pelvic floor muscles just open, right? Everything gets wide. But actually, what happens is it elongates and it becomes a funnel. So all those different layers. I don't know. I used to have this little cup when I was a kid that you could travel with that folded in this little thing and it would pop out. Have you guys seen those? Yeah. Vroom. That's what your pelvic floor does in birth. And then that helps guide, and the uterus has these spiraling contractions, and that's what helps guides the child through. So anywhere there's constriction or tension in that, you're going to be kind of missing your bumpers. So I think that's predominantly why we have some smooth muscle fibers in our pelvic floor. Also, there's just basic tone that needs to be happening all the time. That's going to be in relationship to how your bladder functions, how your rectum functions, and in a birth process. So we have our autonomic nervous supply. So that parasympathetic is going to come from S2 to S4. So the sacral nerve roots there. We have our sympathetic supply. So that's going to come from up above, T12 to L2. And again, it's just so neat, but I think there's general ranges in here. It's never exactly this to this, right? Some people are going to be variant, and it's kind of, it's just all thrown in the mix down there when you start looking at it in situ. And generally, parasympathetic is responsible for releasing and letting go. Sympathetic is responsible for holding and maintaining tone. But that is a really big overstatement. When you start to get into the autonomic and the somatic supply of pelvic floor and pelvic organs, it goes all over the place. Our somatic supply, so the autonomic is going to control the smooth muscles, the organs, any of your secretions, your blood flow, all of that stuff is going to be controlled by your sympathetic and your parasympathetic in the pelvis. And then we have our sensory and muscle motor coordination. That's also going to come from S2, S4, and that's called your pudendal nerve. And what's really fascinating, the word pudendal has its roots, I believe they're Latin roots, in the word shame. So it's kind of like built in this like pelvic floor tension and fear and hiding that we tend to do. I think that's so fascinating. So if we look here, up here are our sympathetic nerve roots. And then here comes, so this is the lumbar sympathetic chain. And here we start to get into our parasympathetics here. Okay. And then this is the pudendal nerve coming in through here. And I've got another picture as it exits through. As we exit through the sacral femina. Okay, so this is our parasympathetic supply to our pelvic floor. Here's our levator. Here's our obturator internus. Up here is psoas, if that's helpful for orientation. So again, it's not this neat. Things are overlapping all the time, and we have viscerosomatic responses and we have somatic viscero responses. So if our soma is irritated, it can feed into our organs. If our organs are irritated, it can feed into our musculoskeletal system. And that's because this is just kind of a big highway of things that overlap, right? So it becomes important when we're looking at pelvic floor dysfunction or organ dysfunction. What's causing that? Where could it be coming from? And what kind of things can we ask to say, can I help with this? Should we refer to someone else? Things along those lines. Any questions? Good. Okay. So pudendal nerve. It's kind of agreed upon that it's a pure somatic nerve, but again, it's overlapped. So some people will say, no, it's actually an autonomic nerve. And this nerve is kind of the one that's responsible for a lot of pelvic pain patterns and can be confused with piriformis syndrome. It can be confused with sciatic pain. But again, it comes from S2 to S4. Okay, and the interesting thing about this is that pudendal nerve passes through. This right here is that sacrospinous ligament and that sacrotuberous ligament. So it has to pass through those, and it also has to pass through your iliococcygeus. If we go back, will it show it on that one? And your piriformis muscle. Okay, so this is your piriformis. Oh, I'm pointing with my finger like you can see that. This is your piriformis muscle, and this is your iliococcygeus muscle, right? So it has to pass back through. It's this guy here. So if those muscles or those ligaments are impaired because of postural defects or pelvic instability or something like that, you're going to be slamming on that nerve. And that nerve is going to be somatic, sensory to your pelvic floor muscles, to your external genitalia. But also, there's a lot of implications with your pelvic floor organs, with your pelvic organs. So there can be things like interstitial cystitis. There can be things like urgency and frequency, which we'll talk about a little bit, but you can do a lot of work with that. So what's important is that it's passing through the iliococcygeus and the piriformis, as well as those two ligaments, your sacrotuberous and your sacrospinous. Okay, and you guys can affect that, right? Um, and when we're looking at pure pudendal pain, when it's coming from purely nerve pain from the pudendal, it's like usually it's burning pain deep inside the pelvis that can come with other dysfunction like bladder function, like gut constipation. Um, so that, but and it won't radiate. It won't radiate down the leg. It won't radiate up the back. It's right there in your pelvis, and it can be really painful on sitting and often relieved on standing. Some of these things mirror also sciatic pain, except sciatic pain, right, is going to refer down usually. And piriformis syndrome, again, they all kind of will overlap, and rarely do they exist in just, one little section. Um, what's valuable to know too is not only are they passing through those ligaments and those muscles, this Alcock's canal right here, this runs medial to that ischial tuberosity, and it is in relationship to that obturator internus. Yeah. Okay. So this is where a lot of the impingement of that nerve can come from as well, because it can no longer slide and glide through that canal. So that's, I think, really helpful landmarking to know when you have somebody coming in and like their back hurts or they can't really explain where it hurts. It just hurts deep, or burning is often a good sign of deep nerve pain. That like, oh, it's on fire. It will usually be a pudendal issue. Yeah. Any questions about that? Yeah,
I
Sophia.
have a quick question. Hi.
Yeah.
So say like in when we do session 4, we go around like sit bones, right? Essentially. Would we also be affecting that like one nerve that you're talking about just now? The pudendal?
Pudendal. Yeah, no, it's good.
Pudendal.
Yep.
Sorry. I'm like reading it, I'm like, oh, she's just said it and I can't like oh my
It's
God.
totally fine. Yeah, absolutely. And you can
Okay.
affect it. You can get through just by if you're going into the inside ischial tuberosity or if you're working through obturator internus, you can do a lot of just release in that area and start to get things moving through. Um, more training is sometimes necessary just to feel the difference between the muscle and maybe what the nerve would feel like. But yeah, you can definitely do work. And then some of the exercises that we're going to do can be helpful as well. And it's not just the nerve, as I was saying, it's also the organs. So let's go one more deep here. So some of the things that we see when there's pelvic floor dysfunction, right, is pain, deep burning aching pain, pelvic instability, constipation, diarrhea. We don't tend to think of that as like a pelvic floor issue. We think of it as like a digestive issue, but I'll show you why it can often be a pelvic floor issue or cause pelvic floor issues. Pain with evacuation. I had a woman, it was so fascinating. Every time she had a bowel movement, she got a screaming migraine. It was such a trip. And in my world, we work on cranial sacral as well. So we're looking at the connections between the base of your skull and the base of your tailbone. It was such a fascinating case. It was like almost so easy to clear up because it was so cut and dry. But like pain with evacuation can definitely be a thing, either urination or defecation. Urinary incontinence and frequency, which we're going to talk about. Other things, erectile dysfunction, anorgasmia, so inability to orgasm, or pain with intercourse, or even tampon insertion. Like this can all be related to all of these things we're going to look at. Hemorrhoids, and bladder pain. Okay, so interstitial cystitis sometimes is a really intractable thing where people just talk about having a lot of pain and they might not have the capacity to speak um, that my bladder hurts. They might just say, oh, it just hurts here. And so these are things that you can start thinking about. And when we think about pelvic floor, most people are interested in understanding pelvic floor because, at least for women, there is urinary incontinence issues, right? And for men, oftentimes there's erectile dysfunction issues, there's flow issues, which can be related to pelvic floor, or there's testicular pain. But you're not going to have most men coming in telling you these things. So these are questions that you kind of either can get comfortable asking or expanding into just to get a sense of how much work do I need to be doing here? How much should I refer out, you know? So when we talk about pelvic floor, we have to talk about all the organs that exist in it, and you'll see here why. Um, so this is obviously a lady. Okay, we have a picture of a man too, but this is your bladder, this is your uterus, and this is your rectum, and this is your pelvic floor. So we were talking about we have autonomic control of the internal sphincters of our rectum and our bladder, right? So there's your body is constantly just keeping those things closed without you having to think about it, right? That's your autonomic supply that just maintains that continence. And then in this external layer, that's the urogenital, the one more superficial. That's where we have conscious control of those sphincters. We can engage them, we can relax them, right? So we can say, now I'm going to go to the bathroom, and we can let go, hopefully. So this is the relationship between the pelvic floor and our conscious control. But I'm going to say this because how many of you have seen pictures of your uterus in the context like this? No, right? Because we always see it in like this kind of like crucified form with like, the ovaries way out here. Okay. Yeah, right. That's not how our uterus lives in our body. So this is my favorite analogy. So the Star Trek Enterprise, the nerdy guy, the show. So if you imagine the disc in the front of that ship is the body of the uterus here, bink, bink, okay? And then the little engines in the back are your ovaries, okay? So every time we have a child, our ovaries widen a little bit, and this angle becomes less. So the uterus actually comes a little bit more upright. Right? And every time we have a child, that kind of happens more. And then you end up with your ovaries a little wider and your uterus a little bit more vertical. And this is important because it changes this angle and how your bladder can function and how your rectum can function. So this can also happen, like women have like tilted uteruses, right? Things that tip back, right? Or they tilt to the side. Um, this can affect how your pelvic floor is able to hold something that is meant to kind of help itself by holding on to the sides of your innominate bones, right? And also using the bladder as a cushion. But we start to lose that, and then it can begin to slide down, right? And then these tiny little muscles are trying to hold an entire organ up. So then we have the potential for prolapse. You do not have to have a child to have prolapse. You do not have to even be a woman to have a prolapse. If you have chronic constipation, or we'll talk about this in a minute, if you push to pee, right? Some people just sit and they just push it all out and go as fast as they can. Or if you're having to strain to use the toilet, you're pushing everything in here down on your pelvic floor every time. Okay, whoops. So this is important because if you're constantly pushing things down, we're going to feel the pelvic floor contraction. If you feel any of that lifting, you're not going to work against a suspensory apparatus that has been lost. Okay. This is a male pelvic floor. Same thing, different parts. Bladder, a little bigger. Urethra, a lot longer. Prostate, and rectum. So if your rectum, if you have constant constipation, right? This is full and is going to be pushing on your bladder, For those of you who have been pregnant, this is why you can't pee or poop when you're pregnant, or why you have to pee all the time, and why you can't poop, because this will get very large and impinge these areas. Um, and they're muscular bags. That's all they are, right? So bladder function here, again, here's your internal sphincter, here's your external sphincter, and for rectum, internal and external, okay? Bladder works in a pressure system. So it's just a muscular bag. And is the ureter on here? Yeah. See this little guy right here? Boop, 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 boop. Okay. The ureter is constantly dripping urine down all day long. So it's not like you build up enough pee and then it comes into your bladder and then you have to go. It's just a constant drip of urine. I always find that fascinating because no matter if you go to the doctor and you have to give them a urine sample, you always have to pee, right? There's always urine in your bladder, but you don't get the signal until that bladder has enough pressure in it from stretching to signal you that, your bladder is half full. So that's the first signal we get is our bladder is half full. And that one we can usually totally ignore, right? You're like, oh, I should go to the bathroom. I'm not gonna. Most bladders will accommodate a cup to a cup and a half of liquid. So at about that halfway point, yep, you go, I have to pee, and I typically most of us will ignore that. And then we'll get a second signal when the bladder is expanding and there's more pressure being put on it again. That's usually the one that we have to listen to. Normal urination should last about 20 seconds. So when you toilet, you should toilet every 2 to 4 hours, and it should last about 20 seconds, and you shouldn't push. So that would be normal. So someone who's peeing more than every 2 hours, or someone who's peeing for like 5 seconds, that's not, you're not getting the full stretch of your bladder. And that becomes a problem and can have a few different origins. Some of them can be if your bladder can't stretch, the uterus can be pushing on it. Also, the abdominal contents can be pushing on it and kind of keep it from being able to stretch, right? So you get a signal sooner that you have to go because the pressure builds higher, faster, because it can't expand as much. Does that make sense? Yeah. Okay. Um, so those are people who have like bird bladders, right? Who you don't want to go on a road trip with because they have to stop every 5 minutes to go pee. Um, other things that can happen are we have those mainly those two signals when we stop ignoring, or when we start ignoring that first signal consistently and going when we absolutely have to go and no else, the body will turn off the signals. It will just not let you know that you need to pee, and then all of a sudden you get a signal and you have to pee instantly. Like there's no changing that, right? So those most often are teachers and nurses. They do not have their own time. They do not get to pee when they want to pee. And so they have learned how to turn that signal off. And so then you get what's called urgency incontinence, this idea of, oh no, I need to pee and I need to pee right now. And you can also have urgency incontinence. Those are usually people who will like power pee, they push through really fast, and they're out the door and they go, right? And then they'll actually have a full bladder and they'll be able to go, but they might not make it on time. Okay. And then we have another kind of incontinence, an urgency incontinence, which is overactive bladder, right? Is like, oh my God, I just peed and there's no urine coming out, right? Just like I'm here for this again. It can feel like a bladder infection, which it can be, but it also can be irritants from diet. So that's another fascinating way to kind of think about what's happening with my bladder right now. Is there something that I'm eating? It's most often caffeine, or alcohol or sugar. It's all the good stuff, but it can be anything for anyone. It can be anything for anyone. And so that's another kind of urge incontinence that's really annoying, that really interrupts people's lives, because if your client knows where all the bathrooms are, and if they pee when they come in and they pee when they leave, you can think, okay, what's going on with their pelvic floor? What's going on with their bladder? What could be happening? because we definitely, I don't know if you guys have been in practice for massage or anything else like this before this, but if you have, I'm sure you've seen those clients. Um, the other thing that can happen is stress incontinence. And this is the one. Oh, yeah. Do you have another question, Sophie? Okay, sorry. The other one that kind of is typically, oh, yep.
I actually did want to just go back to the urgency incontinence for a
Mhm.
second. So the brain has said, okay, well, you don't heed the signal, so I'm not going to give it to you.
Yep.
Um, we can bring that signal back.
Hmm.
Yeah. Okay.
Yes.
Is that part of what we're going to talk about?
If you guys want to talk about that, we can go into it for sure.
I
Yep.
would love to.
So, and brains are fascinating things because of this really complex, there's like 14 different neurological loops that have to happen for us to urinate, right? So we have a sympathetic system that holds our bladder in check. We have a parasympathetic system that is responsible for us urinating. So have you guys ever heard of shy peeing?
Yeah.
No. Yeah.
Yeah.
So like
Yeah.
if somebody comes into the bathroom or like you just can't pee, there's because it requires your parasympathetic system to be calm, to engage the muscles. This is a fun muscle, detrusor. I love that name. Um, the detrusor muscle contracts so we can urinate. So that's one reason, mostly in women, why we can't go because there's this parasympathetic sympathetic imbalance, right? The system is not able to get signals clearly through. And other things like why do we pee when we listen to water? Like why is there that thing that happens, right? Some women, and this is usually women, but men as well, as soon as they see their driveway, they got to pee. Right. And then it becomes as soon as I turn the corner around my house, I got to pee, no matter what, even if you just went to the grocery store. So we develop these kind of psychological tics that get associated with these patterns. So you really literally have to kind of re-toilet yourself and potty train and learn new ways. So it's really helpful. So you're not doing shooting in the dark. You can do kind of what they call avoiding diary. So you just measure how much am I actually going when I go, right? So am I doing a full bladder empty, right? Is am I going about a cup or a little more? So that would let you know, okay, maybe I'm just not getting that first signal, right? If you're going a little bit, and that's going to tell you, oh, okay, either I'm not able to evacuate, or I've got some irritants happening here that's causing my bladder to say, go pee, go pee, go pee all the time, right? Um, the way that you work around that is if you're having that urgency incontinence, you want to make sure that you're going pee like every hour to hour and a half, even if you don't have to go. So that you're not just waiting, because you're probably on the other side of like, nah, I could pee every 3 or 4 hours and be fine. So you're just kind of getting ahead of the game and getting used to it. You could also um, engage the urethral sphincter when you're peeing and releasing. So you're just practicing engaging those muscles, stopping the flow of urine, starting the flow of urine can be really helpful just to kind of wake things up in there. And then um, that's if you're going a full cup, right? That's if you're having a full bladder. If you're not having a full bladder and you're going more often, you're going a lot and you're getting that urge, I have to go now, then you want to practice withholding. You want to practice not going. Um, so this one can be a little trickier. Yeah, go ahead.
So I had a C-section with my son and
Uh,
then natural VBAC with my daughter. After that was in 2001. After that, I don't have the feeling. The bladder doesn't tell me when I have to go.
yeah.
So is that an exercise that I can retrain my bladder to tell me when I need to go?
Are you having other feelings in your perineum?
Um, it's a very slight, nothing like before.
Yeah.
So I just kind of go when I think I should go. Like if I had a whole bunch of water, I go, I better
Yeah, yeah.
go because, but I can wait really long. But that was only since my VBAC.
Oh, yeah. Okay. Um, yes, you can, but you might need some more like pelvic floor support, like
Yeah.
internal work. You
Okay.
might need some more work. But yeah, even a couple of exercises that we're doing, see if
Mhm.
that helps.
Oh,
Yeah,
perfect. Okay.
but you can retrain, and you're doing that, being consistent, like I'm going to go every
Yeah.
2 hours,
Yeah.
just to start getting that feeling. And it's a weird thing to sit and feel urination, but
Mhm.
that can be helpful.
Yeah.
Um, so if you're on the other side where you're going a lot but not actually urinating, that's where you withhold. So you
Mhm.
don't go to the bathroom.
Right.
You go into the toilet and you do calf raises or toe gripping for about 20 seconds to override that bladder sensation. But you might not always make it. So you either want a pad or you want to be ready access to the toilet. Some people have told me they just do it in the shower. So it kind of depends on what end you're at, and that's a whole big conversation. But that's kind of the overview of a couple of ways that you can approach that. Does that answer your question?
Yeah. 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 Yeah.
Yeah, and Kara? Okay, cool.
Yeah.
Um, so that's basic bladder function. The other really important thing here to note is to have good pelvic floor function, you have to have these organs being in good health. So that way they maintain their buoyancy and the ligaments can hold them up. Everything is supporting you. And the final function of the bladder is this bladder neck can be lifted by the obturator internus. So when the obturator internus is engaged and in good tension, it lifts here the neck of the bladder up and helps close this internal orifice. So that's a really important part, is having the flexibility of that obturator internus, not only for that pudendal nerve, but also for your bladder function. And the bladder being able to be mobile in and of itself, not just for the contractibility and the expandability, but even within the pelvic content is really important. Because if it can't lift, if it can't descend, if it can't do those things, then you've got a rock sitting on your pelvic floor. And then if you also have a uterus that is maybe upright or is contracted or tight, you have another rock sitting on your pelvic floor. If you have a rectum that is compacted and full, you have another rock sitting on your pelvic floor. And then you're pressing on all of those nerves and you're pressing on all of the muscles and the blood flow. And then, especially for men, the prostate sits. Do I have? Yeah. So the prostate sits in this beautiful little water bed. It's in a huge venous bed that's constantly pulling blood out and refreshing the blood flow to the prostate. So if that gets stagnant, then what do we have? We have BPH, benign prostate hyperplasia, right? So then we have issues with urinating. So you can affect that by releasing all the muscles of the pelvis, and we're going to go even further, but having conversations about not a little bit about bladder. How is their bladder? How are their urinating habits? Can give you a big sense of how their pelvis is living in general. Constipation. Do they have a history of cramping? Abdominal surgeries are huge, 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 because it creates a scar tissue that's also going to be changing the motility of your gut. So, to giggle or not to giggle? So what I want you guys to do is, we've been taught, right? You can fix all of this just by squeezing down there, right? Like what the hell even is a Kegel? Just do 400 a day. You're going to be fine. Do 400 a day, every day for the rest of your life. You're going to be fine. No, they don't really do anything because we don't know how to do it. Dr. Kegel, the man who developed it, a Kegel was taught with you being in his office, and he would manually feel if you were doing the Kegel appropriately. So that's how you did a Kegel. It wasn't just squeeze something and move on, right? Which is what we have today. So we're going to do, we're going to do a fake thing here. I want you to make a big puff of air in your mouth. Okay. Now I want you to imagine that we're gonna change the orientation of those muscles by moving the bones. So go like this. Okay, try to keep the air in your mouth, but go like this. Impossible, right? That sphincter is not going to be able to stay closed if you're shifting the position of the muscles in the pelvis. Does that make sense? So the sphincter isn't going to work if the framework isn't set properly. Okay, so I think of the bones kind of like the trees, and the muscles are the hammock, right? So if those trees are oriented improperly, then the hammock is not going to be able to swing and move the way it needs to. Okay. The other piece that we have is this stress incontinence, right? So when we cough or sneeze, we take extra pressure from above and we push it down. And this, we're told, is normal. And again, this is more of a female thing, but men can have this as well. Um, and it's just part of being a woman, honey. Sorry. Oh, you had kids? That's just life. It is common, but it is not normal. And it is not an inevitable part of having a child, of having abdominal surgeries, of being a woman. Like, this is not normal. So, again, if you do the same pressure in your mouth and then kind of give a little cough behind you, is not going to stay. So we have to address the pressure systems behind that for your continence to work, not just this muscle. And I will say, most of the time, pelvic floors are too tight, which you guys will feel all the time, is that your pelvis, the muscular tension in there is really, really high. So the tone is very, very high. So it's like if my bicep were constantly stuck in this position and I only had this range, and you're telling me that I'm weak and that I strengthen this muscle again and again and again, I'm actually working against what my function is, right? So we have to increase the flexibility and the tone of the pelvic floor. So that is not necessarily a Kegel, but involves all this other stuff that you guys can have a really big influence on. Um, any questions from that? Yeah, go ahead.
So, Morgan, we do the Kegel with when we are working on the ramus, right?
Okay.
So, and the way that we cue people is typically saying, imagine that you're urinating and you need to stop the flow
Uh-huh.
of urine. And so then most people can connect with that.
Yeah.
And this is the way that we are helping them, first off, like even mentally locate their pelvic floor, because most of us kind of walk around without being able to even mentally find that
Oh, yeah,
pelvic floor.
absolutely.
Um, how do you feel about that as like a movement? It seems to work very well. I wouldn't know what else to cue them to do in order to facilitate the movements. Because, like I was saying before, we're underneath that ramus and then just on top of the ramus. And it's
Yeah.
usually when we're on top is where we're doing that. Do you have any
Um,
thoughts?
Yeah, I do. And we're going to go through a couple of like, what does that feel like? And a couple of cues that I find very valuable. I think
Oh, great.
that can be really helpful just to think about engaging the urethral sphincter or stopping the flow of urine. But sometimes the whole kit and caboodle goes. And if you're feeling that, by that I mean they're kind of squeezing anal sphincter, they're squeezing glutes there and pushing down. And a lot of times people think they're
Mm,
lifting when they're pushing down. So it's a
mm,
Valsalva maneuver, right? And that's again from a pressure system. We push down and we think because we feel something moving in there that it's engaged, right? So
okay.
if you could monitor at pubis and at sacrum. So if you're in kind of this hold, if you were like so, then you would
Uh,
feel more, is there a lot of activity or tightening in that coccyx that would let you know if they're engaging that anal sphincter as well,
okay.
because you
Okay.
don't want to slam the whole system down.
Yep.
Um, and you'll feel it. We'll go through it.
Okay.
So you can
Awesome.
have a better cue. But that's a pretty good one. That's better than a lot of the ones that I've heard. So you guys know what's going on. So um, other things that are involved, which we've talked about, right, is the flexibility of your pelvic floor, your lumbar muscles, your hip muscles, right? And the obturator internus needs to be mobile. That's a really important one. It's kind of like you can think of it as like part of the rotator cuff of your hip, is it can just be small, locked in, and tight, right? So releasing that just frees up some of the deep mobility inside your coxofemoral joint. The nervous system, parasympathetic sympathetic balance needs to be addressed. It has to be addressed because if there is a dysregulation in that, then all of those signals that are going back and forth are not going to get cleanly where they need to go. The gas is on and the brake is on, or the gas is off and the brake is off. So things need to be balanced. You cannot address pelvic floor dysfunction without addressing nervous system balance, which the best thing to do is to breathe. So we'll talk about that too. Diet, So if they have inflammation in their gut, that can be a problem. Um, you can also have that viscosomatic pain that I was talking about. If their gut is inflamed, then that's going to move through into like referral pains, right? Um, Also, if the gut is not motile, I'm going to show you a picture of that, then you'll see why that matters. And then constipation. So addressing diet is always important. Like it's the most basic stuff. It's like breathing, sleeping, eating, how well are you doing those things? It's frustratingly simple because people want something really complicated to be wrong so they can like do something, but really it's everyday lifestyle things that make a big difference. So you guys can really affect pelvic floor and bladder function through what's called kind of the abdominal box. Bink, 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 bink. How much of your work involves these muscles? Like all of it, right?
Oh, yeah.
So um, anything in this abdominal box, we have muscles here. If these are tight, you're tightening and you're increasing the pressure in your abdomen. That increased pressure is pushing down on your pelvic floor. And we have the same problem. So if you're not addressing what's going on above the pelvic floor, then you might feel good for a little bit, but it'll come right back because you're still like Atlas trying to hold everything up. So you have to address all those things. So you guys, I'm sure, know how to do diaphragmatic breathing, yeah? Is this something that we're taught? No? Okay. This is
I mean,
vital.
maybe, right? Like
Maybe. Okay.
I've seen it taught a lot of different ways.
Okay. So, um, respiratory diaphragm and pelvic floor diaphragm need to move in synchronicity. So when you breathe in, the respiratory diaphragm, that central tendon there, it descends down into the abdomen and the muscles around the outside, right? This is diaphragm, which attaches really all the way down to L4, but here's another big mess of ligament tendinous, right? It all goes together. So that central tendon descends down, the whole thing widens. Our pelvic floor does the exact same thing. So first, let's start. Bring your hands wide on your rib cage. So ladies, like right around your bra strap. Okay. And you're going to breathe in to your hands. So when you breathe in, you're going to feel that you can widen, and then you're going to breathe out, and you should feel a natural narrowing. When you exhale out, I want a soft sound, not a pushing. So it's literally falling out. So when you breathe in, the whole diaphragm descends, the central tendon will move down towards your belly button, and the whole diaphragm widens. When you breathe out, relax your air out. And then keep letting it fall out. And you'll notice it narrows. Now, this is what people often do. Do a big belly breath for me, like you're in yoga, doing a huge belly breath. Do you notice your diaphragm doesn't move? That is not a diaphragmatic breath. But that's what a lot of people consider a big breath to be. So you can see someone take a very large breath, but they're still not moving their diaphragm at all.
That's what I was hoping we would get out of this. Thank you.
And legit, if you take nothing but how to do this breath and to teach people other people to do this breath, this is so important because it addresses your nervous system balance. It addresses this idea that your pelvic floor and your diaphragm need to move together, right? So if your pelvic floor is rigid and your diaphragm moves, you're hitting and smashing your pelvic floor every time you breathe in. Or if we look to this picture, so these are abdominal box, like this is all muscles that you guys know how to release, right? Like psoas, iliacus, your QL, your paraspinals, your pelvic floor, your diaphragm, all that stuff. You guys know that, right? This is good. You're good. This is everything else that's in that system, right? So here is your diaphragm. This is your liver, your stomach, your pancreas, your kidney would be kind of out here. And these are your small intestines, bladder, and large intestines. So anything in here that is not modal, functioning, or moving sits on your pelvic floor. And then we say that poor pelvic floor, come on, just work harder. Mm. Okay. And then you add pelvic skewing to that, and you add this like your trees are off. It makes it very hard for it to work. So every time you breathe in, your pelvic floor is your respiratory diaphragm is pushing down. Imagine washing a big shirt or clothes in a bucket, right? You push down, you pull out, you push down, you pull out. That's how you create the proliferation of soapy water to get your clothes clean. 20,000 times a day we breathe. 20,000 times a day we should be doing this through our abdomen, juicing our guts, and moving all of the organs of our pelvis, pelvic floor, and our diaphragm every day. Nobody does that. So, what does that feel like? More importantly, so we only have one person with a tennis ball. Okay, I'll talk to you about a tennis ball, but you can use a towel. So just take your hand towel and you kind of want to roll it up. So I have it in thirds. And then I guess you can do quarters. Actually, what I would do is fold it in half and then fold it in third again. So you folded it in thirds longwise. Okay. You really just kind of want to make a ball.
Oh,
You fold that in half and then take that and roll it into thirds. Like so. So you end up with just this little thing. Okay. Then what you'll do is this goes right into the center of your perineum. So you're going to sit on it. Okay. And depending on the size of the space there, you can sit on it this way or you can sit on it this way. If you sit it this way, I think you guys will feel a little bit more. If somebody is very sensitive, make sure they sit on it this way. Okay. So that way you just have a little bit of pressure in there. Bink. Okay.
I have a question.
Yeah.
I think for Cara too. So like during session 4, when we're doing a lot of pelvic floor stuff, should we be having the client doing a lot of diaphragm breathing in order to loosen up everything above the diaphragm, above the pelvic floor? Just that it would be, we should do it in all the sessions, but is that something that we should have them do quite often during a session?
I mean, that's a great question. And I think my answer to that is yes. But
Because
we have
till
not
she
taught
said,
it that way.
yeah. Till she said it like that, how everything is pushed down because nobody's doing that type of breathing. That
Yeah.
if we do a lot of those breaths, especially during a session when we're trying to release some of the pressure from the pelvic floor, why not have them do a lot of, diaphragmatic breaths during
Yeah.
the session to help? Yeah.
I love it.
Yes.
That's
Right.
great.
And this is also something the client can do to maintain their own health,
Mhm.
right? Because you're addressing the nervous system. You're also giving them a tool that they can do because many of them want tools. And so
Mhm.
this is like, okay, so now we've done this beautiful work. Here's how you maintain it at home, right? Here's what you can do to help support this work when we're gone. Um,
Ugh, you know
and
how annoyed
here's this
people
too.
get when you just tell them to breathe?
I know, but here, this is a really helpful tool. Is they've done
It's a
studies that
great
show,
tool. Yes.
yeah, but
For anxiety.
breathing twice a day for 5 minutes, a diaphragmatic breath, that nice, it doesn't have to be big, but it has to come from your diaphragm. They've done studies that show it's as good as a Xanax. The
Yeah.
only issue is you can't do it in the moment of a panic attack. You have to be proactive about it. It will work kind of if you're in a crashing, burning plane of a panic attack, but you need to be proactive with it.
And that's where a box breathing comes in.
Yeah,
4
same.
seconds,
Yep.
breathe, breath, hold, 4 seconds, 4 seconds, breath, 4 seconds,
Yep.
hold.
And if you add this awareness that they're not breathing like this,
Yeah.
and just activating their sympathetic system again, but teaching them to move their parasympathetic system, then you've got two fronts.
I have a client that doesn't breathe at all in the upper
Yep.
chest. She just
Yeah.
needs to do it a lot more. She just needs to practice that a lot more or show her
Right.
how to do it. Maybe she's never really
Show
actually
her.
fully done one before. If I show her
You
diaphragm,
have,
how it expands when she breathes, instead,
yes.
because I had her do a breath in the very beginning of a session and it didn't move at all. And I was like, oh my gosh, how are we going to open that one up?
I mean, we really should be teaching every single person who comes through our door how to breathe.
Yeah.
It is one of the most fundamental things that we need to have a good life.
Yeah.
And it's simple. And I've had clients for years and I will ask, Have you breathed? Are you practicing? Are you doing it? And they're like, oh, I thought about it. So, it's consistent. So, yeah.
Oh my God, I've thought about it. It's like great. Um,
Good. You're
uh,
getting there. Keep going.
I just had a new client and I gave him a session one, which is like all about freeing up the diaphragm and all that, right? And when I was like doing the rib work, kind of like around the costal arch, I was like, hey, like breathe up into your lungs, and I was like, your lungs come all the way up here, and I like a little spiel. And he was like, yeah, I'm breathing into my lungs, and he was, but he couldn't not like push his belly out while
Yeah.
he was breathing. And I was
Yeah.
like, do you belly breathe on purpose? And he's like, I'm belly breathing.
Yeah.
um, and I didn't know how to cue him or like how to help him like stop moving with his belly because it felt really forceful, and it actually made the rib work harder because it felt
Yeah.
like he was like pushing his belly out.
Yeah.
Um,
And
and
again, sorry, are you?
oh yeah, no, I was just
Yeah.
gonna say, do you have any like tips, tricks?
Yeah. It's the important part is people associate good breath with big breath.
Mm.
Mhm.
And that does not equate. A big breath doesn't mean you're doing a good breath. If I'm doing all of this accessory breathing like this, all I'm doing is
Yeah.
increasing strain here and teaching my parasympathetic or my sympathetic system that I need to take, running breaths.
Hmm.
So it's saying don't take a big breath, just breathe normal for me, and then trying to get their awareness into expanding a side of their rib cage or expanding into the table. Or if you have women or men, what does it feel like to keep a strapless bra on? Right? That we've all done, right? Is that
Hmm.
external connection. But I think dissociating big breath equals good breath is a good place to start. And letting
Okay.
people know that when you breathe in, that's the muscular contraction. So your diaphragm contracts on your in breath. When you breathe out, it's a release. There is no muscle
Okay.
contraction that has to happen when you breathe out. So literally letting it fall out. So open mouth, breath falling out rather than like a forceful breath, which some people do, or they push from their sternums or they push from places. It's just relaxing. But it takes, just like pelvic floor, it takes a long time to really be aware of like your diaphragm. Most people are aware they have a front, and if the back of their body hurts, they have a back, but there's nothing else.
Yeah.
So
Hmm.
it's a practice.
Like
Yeah.
you said before, if you hold underneath here your bra straps and you do a big diaphragmatic breath, you can feel that. So someone that
Yes, you can.
doesn't do big breath, if they start here until they feel their rib cage open, then they know they're doing a big diaphragmatic
Yep.
breath, right?
Yep.
So yeah, too.
And
Hmm.
yeah, I'll frequently just tell people, don't worry about how big your breath is. Only breathe as much as you can feel an expansion in your rib cage. And
Mhm.
for some people, that might be a really shallow
Yeah.
breath.
But if
And
they
saying,
feel it, yeah,
yeah,
then they could learn how
then
to
they can
do
work
that.
on expanding it.
Yeah.
Hmm.
Exactly. So they might get lightheaded. They might start yawning. They might do all kinds of things. It's not, so they might only be able to do 3 or 4 breaths before they're like, oh, I have to reset and take a big breath. That's all normal. Okay. But since we're sat here on the towels, um, take a big diaphragmatic breath in and feel how when you breathe in, there's pressure going down on that towel. If there is not, then we have a pelvic floor dysfunction. A lot of times people will feel it lift away from the towel when they breathe in.
No, I don't feel that.
Yeah.
I don't feel
So so this is one place to start,
it. Mhm.
is just having a towel. The other thing that you can do is you take your pelvic, your tennis ball, and I'm sorry, I didn't catch your name. All I see is iPad 13.
Oh, sorry, Debbie.
Debbie, okay. So Debbie, with like having no feeling in there, right? We have to start getting feeling. Is you take your pelvic floor, your ball, you
Mhm.
start on your sit bone and
Mhm.
you roll into one half of your pelvic floor and you do the same thing. So you're getting specific on one half of that pelvic floor
Mhm.
and you're getting pressure in there. And it will also start to release those muscles.
So pressure will release, and that then there will become feeling. Then
Yep.
after.
Yep.
Okay.
Because you need to have more, right? It's slide and glide. It's
Okay.
where's that fascial mobility, right? And
Mhm.
then as you're breathing, you're getting internal input from the organs and everything, the floor pushing on the ball as well. So you get it double-sided. And it can take a long time to rebuild awareness in your pelvic floor, but the best thing is to meet it with consistency every
Mhm.
day, even
Yeah.
for like a minute. It doesn't take much.
Right.
Okay. Did everybody else feel some movement down into your pelvic floor as you were breathing in? Many times you don't feel anything. It stops like at your navel. Yeah.
Maybe like a little bit, but I don't know.
Yeah. Try it when you get your hands on a tennis ball. Do not do it with a lacrosse ball. Do not do it with a cue ball. Don't use those things. They are too hard. Please. People have come to me with crazy things. Don't do it. A tennis ball, you can walk by an old tennis court and find one that's really
Mhm.
squishy. Okay.
An older one, an
The
older
older
one.
ones. Yeah.
Oh,
Those are
okay.
nicer. Yeah. Especially
Hmm.
if you have somebody who's very hyperactive, or hyperreactive. So that's one thing to
What
start.
about a squash ball? Because
Um,
they're really
they
rubbery
might
and like
be, yeah,
squishy.
they're
But
rubbery.
would they be too much, like too squishy?
Sometimes they're too small, I think.
Mm.
They might be, but you can play with it. Yep.
Okay.
Um, but that's one thing to practice is how do I feel those things happening in my pelvic floor? How do I feel that movement? And where does my breath stop? Many women will stop at a cesarean scar. Many women will stop right before their ovaries. Men will often stop right at their navel, like they won't go down even further, or even their diaphragm sometimes. So it's practicing sending that breath down. And now just take the towel out since you've been on it for a while, and you'll notice the lack. And you'll feel, if you take another big breath in, oh, maybe there's more space there. Maybe there's an expansion between your tailbone and your sit bones, right? And if you don't feel anything in your pelvic floor, can your diaphragm move better? As I've softened that pelvic floor, do I have more mobility in my diaphragm, right? If you do, you've addressed your pelvic floor, even if you don't feel it. Okay, because sometimes it's just cut off. We don't feel that area for so many reasons. Again, the roots of that pudendal nerve being in shame is so spot on. And the tension that we hold in there is really, really powerful. Um, so that's one way to start feeling your pelvic floor. We're going to do a little bit more engagement as well. And there's a lot more things that you can do, but that's a good place to start. Um, the other thing that's helpful to notice is you guys talk about posture. Bing, right? So working with posture, getting yourself aligned, the pressure of your pelvis and your organs should rest on your pubic bone. If you're in a different position, there isn't a picture of one that's in an anterior tilt, but it's the same thing. Everything shifts just really far forward, and then you start grabbing in the posterior chain, trying to make up for it and putting more pressure this way in your system. But posture is really important for pelvic floor function because now I have a bone in good posture that's supporting me versus pelvic floor. Right? And then this is important when you're talking about people who have prolapses, right? Or people who get really heavy in their pelvis. Oh, my pelvis just feels really heavy. Or if I'm on period and I feel really heavy, those are signs of organs that are sitting too low in your pelvis. Even if it's a 20-year-old coming in with cramping and they're feeling pelvic heaviness, that is not, again, common, but not normal. So we can talk to them and say, hey, you can do more things because if this is happening now, this can be a problem later. Okay. So let's do a little bit of the levator group. So this is the cue that I like best, but not everybody likes it. But what you're going to do is you're going to take the tip of your thumb and put it behind the front teeth. Right here. Okay. And then you're going to imagine that this is a big, thick milkshake, and you're going to suck on your thumb as if you're trying to pull a big, thick milkshake up your thumb. And what you should feel is a lift. Now, if you were on the towel and you didn't feel much of anything, this might also be like, huh? No man's land. Okay. So nothing is something. If you feel nothing, that is an indicator that, wow, I need to be in touch with my pelvic floor. And if you have a history of somebody who have a lot of falls to their tailbone, vertical whiplashes, horse riders, athletes. You have women who have a history of pelvic floor or menstrual pain, right? Even, I don't know if this happens, but if it comes up, if there's any kind of history of sexual trauma, right? These people are not going to feel anything in their pelvic floor oftentimes. Okay. So
the Butte County Sheriff's Office is issuing evacuations warnings for the following areas in Zone 317. Richardson Springs Road, Grindstone
Sorry,
Road,
my
Big
phone
Log
is
Road,
saying
that's
there's
okay.
an
Cliffs Drive.
emergency.
Oh,
Prepare to evacuate.
is that a
There must
fire?
be a fire.
Yeah. I have not yet received that.
Okay.
Well, let me know if
Richardson
that's,
Springs, that's not close to us.
oh, that's an hour away. Okay.
Yeah, okay.
Yeah. Oh, okay.
Fire season, y'all. All right, please
Yeah.
continue.
Yeah. So let's try this one more time with the idea of just feeling where your anal sphincter is living in your body. Okay. So thumb, back of teeth, give that big suction up, and you'll feel even maybe some abdominal engagement in the front. You're on your way if you feel a little bit of tightening in the lower abdomen. But ideally, you feel more pelvic floor lift than you do abdominal contraction in the front. So that's telling you there's an imbalance in that. Other things that work for some people are a sound or a zzz sound, but you have to be careful with that because some people will push down. So again, that's why I find that hold, the sacral pubic hold, a really nice way because you can feel if there's a pushing tension, a tightening tension versus a lifting tension. So when we're engaging the pelvic floor, it's that levator ani group that we're looking for. So that it's the anal sphincter. You can feel it because the anal sphincter will lift and move slightly forward because of that puborectalis. Let me get back to this guy. Because of this puborectalis right here, right? So when we're engaging this whole thing, it's a movement up and in and forward. Okay. Other cues that some people like, I really hate. For women, so one of the cues floating around right now is like it's a blueberry, and you're gonna pick up a blueberry with your vagina. Okay, that works for some. For men, it's the idea that you're pulling your scrotum up and in is the one that's commonly used for men is can you pull the scrotum up and in, or you're trying to keep your testicles from cold water. So it's that feeling. And when you're looking at pelvic floor work, we have two types of fibers. We have the long fibers and the short fibers, right? So long fibers are for sustained muscle contraction. So you're engaging pelvic floor and you're trying to hold it to weakness. So you're engaging and you want to ideally be able to hold at a sustained contraction of about 50 to 60% of your contraction, not 100%, 50 to 60% of your contraction for 10 seconds. Most people will get to 3 or 4 seconds and then they get weak. So your goal is if you can hold 3 seconds, you're going for 4. And you want to do that until you can, I would say only 6 or 8. You don't need to do a whole bunch. But if you feel weakness that you can't even bring it up to that 3 seconds, you're done. That's it. But you can do that multiple times over the day. So that's to support your long sustained contraction. For the quick contractions, for your stress incontinence, right? For the sneezing, where you need to have an increase in your pelvic floor pressure to prevent leaking, that's where you practice quick engagements. So you tighten all the way up. I don't know, people are moving away from this, but I still like it. It's the idea that your pelvic floor is an elevator. So you want to take that elevator all the way up to floor 10 out of 10. So you're engaging and coming up as fast as you can, holding, and then releasing to basement floor like 3. So that we can often contract, we often can't relax. So again, it's not about how strong it is, it's about how flexible it is. Where is that capacity to do its full engagement? So you have those two things. You have the long sustained contraction at about level 4 or floor 5, 6. And then you have quick short contractions where you're working that. And then you can learn to front load. If you have stress incontinence, you can learn to front load and engage that before you sneeze, right? You can just quickly grab it, sneeze, and then you're good to go. when you're looking at pelvic floor work, it's all of those things that we were talking about before, working the abdominal box, working your nervous system, talking about diet, retraining toilet patterns. All of those things really need to come together if you're looking at a true pelvic floor issue. You guys have a lot of tools for that. And when we're engaging the pelvic floor, it never works in isolation. So for really good long-term maintenance of it, you're learning, how do I engage my pelvic floor when I engage my inner thighs? How do I engage my pelvic floor when I'm engaging my glutes without like slamming on? Most people will just lock down on their anal sphincter and say, good, I'm grabbing my pelvic floor. That is not a pelvic floor contraction. That's an anal sphincter contraction. And I will tell you, lawyers do it big time. So, and I taught out of the country for a year, and I did not tell a single person to let go of their anal sphincter, which, let me tell you, this is a thing I say on a daily basis, almost all the time, until an American walked through that door. And that was the first time in a year that I said, let go of your anal sphincter. And I was like, oh, what is even happening here? So I think it's just part of our, maybe our puritanical roots. I don't know. But learning how to engage it in the system with, inner thigh work, with hip rotator work, with abdominal work, with all of that kind of stuff is really where the true power comes in, and that you're not having to constantly manage your pelvic floor or your bladder or your bowels. So that's kind of it. Yeah. Okay.
Okay, so maybe just the chair that I'm sitting on also. Uh, but so doing some of that pelvic floor engagement makes the back of my back hurt, like right around where my diaphragm is.
Exactly. So this is some of that co-contraction, these faulty contraction patterns that we have is we tighten our low back instead of actually engaging our pelvic floor, they become over contracted together. This is very, very common. So what you can do to practice that, and especially if you're not feeling any pelvic floor lift, is you lie on your back, you put your feet on the wall, so you're at a 90-90, right? And then you put a big ball right in between your inner thighs, and you just exhale, and you feel that you can squeeze the ball, and you can actually add just the tiniest bit of internal rotation, and that will start to widen the posterior part of your pelvis. So you
Okay.
start to get a little widening. Oh, I can't really see it here. You get a little widening back there that can sometimes disrupt that connection.
Nice. Okay.
Yeah. But
Okay.
that's definitely something that if you have someone who's continually, you're like, I don't know, man, we've done good back work, like, and it's still coming in, then there's it's that deep, like L5S1 grabbing, aching that can sometimes like feel like they're collapsing or feel like it's just like you can't get up right in that spot.
Yeah.
That can most often comes with that inability to actually engage the pelvic floor properly and get the inner thighs to work. Those things will work in a negative pattern.
Great. Thank you.
Did that answer your question?
Oh yeah.
Okay.
Yeah.
All right.
Great.
Um, but yeah, that's pretty much the overview. I hope you guys kind of find that helpful. I don't know how much you talk about organs or that kind of thing in your practices. I do all the time, but having that overall picture kind of helps me understand why Kegels don't work. And like what you can start to do to help people who are having pelvic pain or back pain, like Kara, like you're experiencing there, and learning how to disrupt those patterns because they can definitely be intimately linked to that pelvic floor patterning. Yeah.
That's great.
Yeah. Any other
So we
questions?
haven't gotten to session 5, which is the abdominal and all of the organs and everything of the abdominals. That's next
Oh,
week.
yeah.
So
Yeah.
you're kind of like um, giving us a lot of information over what we just did and what they're practicing now, and as a beautiful lead in to where we're going. So
Good.
this timing is very good.
Yeah. Cool. And I will also say feet and pelvic floor, your feet are diaphragms, just like your respiratory diaphragm, just like your pelvic floor diaphragm. So they should also do that breathing thing with you. So if there are feet issues, they're also up the chain. There's also pelvic floor issues.
Yeah.
Which you
So
guys
good.
know. Yeah. You
So
guys,
good.
I'm assuming you guys are learning that. So it's just nice
Yeah,
to think about. So cool. Well,
I love it.
I am willing to take any questions. Kara has my email address, so please. I do teach like more pelvic floor classes and more exercises and things like that. And I'm toying with the idea of doing it online because some people want it who are not available in Chico. So
Chico, yeah.
yeah. So if you're interested, have Kara send me your address and I will keep you informed.
That's great. That's great. Anybody have any further questions right now? No. Okay. Morgan, thank
Yeah.
you so much.
Thank you,
This was
Morgan.
really
Thank
helpful.
you.
Good. Thank you.
Love it.
I like to just spout my mouth off about this stuff. It's so fun.
We're very lucky to hear it.
And good luck in the rest of your studies. Thank you for being people who support bodies. We need more.
Thank you so much. We appreciate
Thank you so much, Morgan. Thank you.
Have a good afternoon, everybody.
it. All right, you too. Bye, guys.
Bye.
Bye.